So maybe we'll get started, at least with the introductions, and by the time we start, everyone will be here. So today, great to have Dr. Frangou and Dr. Strakowski, who are thought leaders in neuroimaging and are going to be speaking about their own perspectives on the evolution of neuroimaging models of bipolar disorder, each from their own perspectives. A reminder, this is our last Toronto Bipolar Research Rounds for the academic year. Jess Barton from our group will be sending out the CME certificates in the coming weeks, and we'll also send out a lineup for next year. Most importantly, for those who have been attending, please consider sending this forward to your networks. It would be great to have even larger international representation at these rounds. We've always had enthusiastic speakers who are dedicating their time to present virtually to us and express their candid thoughts in this intimate venue. So it's just great to have you here today, Sophia and Steve. So Dr. Sophia Frangou serves as professor of psychiatry at the Icahn School of Medicine and as chair in brain health and associate dean for research at the Faculty of Medicine at UBC. Her work focuses on elucidating the brain correlates of psychopathology and cognition across the lifespan in healthy individuals, as well as people with schizophrenia and bipolar disorder. She's published over 300 articles, received numerous awards for her work, including the 2019 Colvin Prize for Outstanding Achievement at Mood Disorders Research from the Brain and Behavior Research Foundation. She was also a 2020 Educator Award winner and 2022 George Thompson Award winner from the Society of Biological Psychiatry. Sophia, thanks for joining us, and over to you.
Thank you. And also currently the president of the SOBP. Although the overall theme is about the evolution of neuroimaging models of bipolar disorder, I will be a bit more forward-thinking. And I also thought that this would be an opportunity for me to share with people on the call some of the resources that we have developed and in terms of infrastructure models and pipelines, in terms of doing neuroimaging work in bipolar disorder, but across the board. So if that is okay with everyone, I will spend the first sort of 7 minutes just telling you a little bit about the resources that we have built to enable large-scale collaborations in neuroimaging. So I will talk a little bit about our data vault, the normative models that we have developed, the normative brain age models that we have developed, other computational pipelines that we have available, and the fact that we can host a large number of analysis and data because we have access to supercomputing infrastructure, both at UBC and at the Icahn School of Medicine at Mount Sinai. I will focus a little bit more specifically in youth, but the pipelines are actually lifespan pipelines. So we have been collecting data through the Enigma initiative, but also through public data sets on, and those are multimodal neuroimaging data on many individuals, healthy individuals, because we were interested to set up the normative framework for brain analysis. So in most of the medicine, when you go to see a clinician, a psychologist, or a doctor, they will take some sort of measures and they will refer them to some normative range. And this will help with their diagnosis and their prognosis and all the rest. Despite the fact that we have had now more than a decade of intensive neuroimaging, there is no standardized way of understanding the normative framework of brain organization. And one of the big sort of areas of focus of my research is to provide just that. So we have started creating a data vault, which has about 20,000 individuals between the ages of 3 and 30, and over 60,000 for the entire lifespan going to the age of 90. So we have a lot of data that we can use to build models for healthy individuals and facilitate comparisons with clinical populations. We have also devised and a huge number of computational pipelines. Here, I'm just focusing on the normative pipeline, which is essentially creating a normative reference range for different brain measures. At the moment, the ones that we have completely available are brain morphometry and brain age, but we are working on functional networks and T1, T2 ratios. And the idea is that very much like when you have other growth curves for pediatrics, that you can actually position every individual in terms of their personal deviation from the normative mean in terms of centiles or Z-scores. We have created a website which is essentially designed from scratch from people from the University of British Columbia, and it's hosted within our systems. You can see the address at the bottom. It's a very easy system to use, and it will give you normative morphometric data as well as brain age, both developmental brain age, sort of focusing the very young people, 5 to 22, but also lifespan models of brain age. We can have a huge discussion about how exactly we develop these models, but that's not the point of this particular presentation. But the paper that describes everything that has gone into this was published early in March, by Lancet Digital Health as open access. So you can go and see more details there, but also I will encourage you to visit the website here and explore a little bit all the functionalities that we have available in case they are of interest to you. We also have a computational pipeline for virtual histology, where we actually map gene expression to different changes in cortical thickness, mostly within the brain. And I'm just giving you one example about the changes in gene expression for different cell types from the age of about 3 to 90 in one of the samples that we have in healthy individuals. So it kind of looks as to changes in cortical thickness and changes in cell-specific gene expression. And of course, we have pipelines for multiple models for doing patient stratification. Those are machine learning models that are actually addressing the issue of heterogeneity. So a lot of the focus that we have within our group is to move essentially to a space where we can have inferences about normality on an N of 1, which is what we call personalizing neuroimaging. So this is really also part of the evolution of neuroimaging more generally. So we have moved from smaller sample sizes and case control designs to much larger data sets and more advanced computational modeling, and also different ways of understanding the evolution of the brain, the trajectories of the brain over the lifespan in healthy individuals that can help us make more meaningful inferences about where abnormalities might lie in clinical populations, including bipolar disorder, but not just that. So I will stop here and see if anybody has any questions about these resources. I think I can answer one or two before I go into the more bipolar part of the discussion. If that's allowed, actually, Ben, is it allowed?
Yeah, that's fine. I think people can either unmute themselves and ask if they have questions or type them in the chat. I don't see anything in the chat.
Okay. Fine. So no questions, so we're moving forward. So here we are going to focus specifically on the work that we have been doing on bipolar disorder. We have moved, a lot of the previous work that we have done has been mostly in samples of patients with either established bipolar disorder or their unaffected siblings, and they were mostly within the adult range. So the new focus of our work has been mostly to address very specific questions that have to do with the early onset of bipolar disorder, but also the interplay between the psychosocial context where people develop actual brain development and how we understand brain development, and how it may modify the risk for bipolar disorder or the risk of any disorder in people with familial risk of bipolar disorder. So these are our 7 key sort of things. We're interested in defining the neuroimaging features of pediatric bipolar disorder to specify whether these features are individual to bipolar disorder or are generically shared with other disorders that involve emotional dysregulation. We're interested to see, we know that familial disposition is one of the greatest risk factors for bipolar disorder. So we really want to know what is the evolution in terms of brain organization of familial risk, starting from people that are unaffected and going forward, prospectively looking at people at different stages of their lives and how their clinical presentation may change or remain asymptomatic. So both looking at resilience, but also at risk. We also are interested if there is any specificity for the clinical outcomes, if there are any features that predict a specific outcome or just features that predict a negative or adverse outcome. We are also interested to look at the psychosocial context and exactly how it interfaces with developmental processes and with the risk or disease expression for bipolar disorder. So that are the sort of big focus of our program. Of course, I will not talk about all of this. I will just use one study that we're doing as an example. And hopefully I will be coming back later on in the next few years to give you updates of how we proceed. So what we do know about bipolar disorder really, and not just bipolar disorder, but a lot of disorders that have that are dominated by a loss of control or voluntary regulation of emotions. You have the involvement of the ventrolateral prefrontal cortex, hippocampus, and amygdala, both in terms of structure, but also in terms of functional activation during different tasks. And you have ventrostriatal and ventrolateral and prefrontal cortical abnormalities during reward processing. And of course, there are multiple changes in terms of brain structure that have been captured very clearly by the Enigma bipolar working group that has put together very large samples doing case control comparisons. So the question that we are asking specifically in the data that I will show you now is what happens when people are young, when bipolar disorder and other mood disorders begin when people are young. All the data that I have shown you, most of the data that we're working with comes from the Adolescent Brain and Cognitive Development Study. This is a landmark US study that involves, it's a longitudinal study. The design is very close to epidemiological, so you get a sense of a relatively representative sample of 9 to 10-year-olds that live in the United States in 25 different sites, recruitment sites. And so far, the initial enrollment sample is about 12,000 people, 11,880. So the study has been going now for 5 years, and the retention rate is very high, but also it gives us the opportunity to actually track individuals through time, and things will become a bit more interesting as they come in mid-adolescence, when we have most commonly the onset of many psychiatric disorders. So these are community recruited individuals, not clinical samples, which is another plus of this data set. And of course, the data set is very large and has multiple different variables that characterize both brain organization, but also the psychosocial context in which these children, these adolescents actually live. So all the sample that I will be discussing today comes from this specific study. Here we ask the question about what happens for youth that are already diagnosed with mood and anxiety disorders, whether they have any neuroimaging features that can identify distinct subgroups within the sample, and whether the subgroups align with diagnostic labels. So in sort of simpler terms, is there any neurosignature in the early presentation of mood and anxiety disorders that is actually diagnosis specific? That's what we were asking. And the reason we were asking this question is that very often people talk about the clinical heterogeneity of this, that, and the other. And we just wanted to understand to what extent changes in the neural circuitry are actually reflecting this heterogeneity or not. So the sample, as I mentioned before, comes from the ABCD study. We do not use all the entire sample, but selected the subpopulation based on the criteria that we see here. So we had about 3,000 typically developing adolescents. And then we had adolescents that had a specific diagnosis of depression, bipolar disorder, anxiety disorder, or comorbid anxiety and mood disorder within the sample based. All of these have been diagnosed with a computerized version of the KSAT, which has its proponents and people that are skeptical, but at least I think given the size of the sample, we can accommodate some uncertainty about diagnostic disorders. And of course, we used machine learning as part of these pipelines that we have developed to multimodal neuroimaging phenotypes to identify the different clusters. And then we asked the question, are these different clusters different in terms of their diagnostic composition of the individuals allocated to each sample, and do they differ in terms of other characteristics like cognitive function or adverse or positive family exposures and other social exposures. The algorithm that we use to do the classification, we have actually tried many different ones, and we will soon have a paper out comparing the dominant different machine learning approaches that we have for patient classification. And Hydra is one of the most robust ones, and its big advantage over other models like support vector machine is that it actually sort of inherent within the design of the algorithm is the realization that patients do not differ from controls in just one direction. So support vector machines assumes that all patients differ from controls in one particular dimension, and they're trying to find the hyperplane that defines this dimension. The Hydra or heterogeneity through discriminant analysis model use multiple hyperplanes and ask the question, are there multiple dimensions where patients actually may differ from controls? So the controls is the reference population again, and it accommodates really the fact that the control population is also not monolithic, but it has a lot of variance. And it asks the questions based on the characteristics of the control sample, can we find clusters in patients that differ significantly from each other and from controls? That's the ask, essentially. So the input features were cortical thickness, cortical surface area, and subcortical volume. We also used a measure of intracortical myelin. Now, a lot of people do not particularly like the gray-white matter contrast as a measure of myelin, but a lot of other people think that it's a good proxy for the cortical microstructural organization that reflects myelin content. And we also looked at neurite density in cortical and subcortical regions. So those are the features that went in. So the features go in without labels. The only thing that is being labeled is the control. So you have essentially patients, clinical population, controls, your input features, and then Hydra is trying to find clusters within the clinical population. And there are different ways to identify when you have reached a good clustering solution. And one of these measures is the adjusted RAND index. And here we see when this sort of index peaks, it's a good sign that it has reached a sort of a good level of clustering. And in our case, it identified 3 clusters. So we're looking at the 3 clusters now. So we have very imaginatively called them subtype 1, 2, and 3. And here you see their characteristics going from top to bottom in terms of cortical thickness, cortical surface area, subcortical volume, gray matter contrast, and neural density in the cortex and in the subcortical structures. So the bottom ones are neural density, the top ones, cortical thickness. And there, of course, we can spend quite a lot of time going through the specifics, but I will just focus here on the sort of big features of this thing. So subtype 1, comparable to the typically developing group of individuals, had essentially larger subcortical volumes, that was its key characteristics, with globally greater surface area expansion and lower thickness, but higher intracortical myelin in the dorsal prefrontal cortex. So those characteristics are characteristics of accelerated maturation of different brain systems. So that's subtype 1. Subtype 2 was really was characterized by globally higher thickness and lower cortical surface area and cortical myelin and lower neurite density in the key cortices. And this signature is really very similar to what we would call delayed maturation pattern. And the third subtype was just atypical. It had a mixture of abnormalities that were not really directly relevant to specific deviations from a developmental trajectory. So subtype 3 was characterized by lower cortical thickness, globally lower surface area, lower cortical volume, higher myelin, and higher neural density. This persistently higher neural density is one of the features that we all very often see in typical neurodevelopmental disorders that are associated with some degree of cognitive dysfunction. In the next slide, we look at the diagnostic composition of the clusters. As you can see, the clusters really have a mixture of people with anxiety disorders, bipolar disorder, depressive disorders, and comorbid disorders. So suggesting that there is really very little specificity that is aligned with the diagnostic labels, but there is something about people with abnormalities in mood regulation that it's shared across the different diagnostic levels, and it's connected directly with patterns of accelerated, delayed, and atypical brain development. And of course, we are very keen to see in the future how these clusters will evolve as the kids continue to grow. And this is a summary of all the psychosocial variables that we examined and looked at how they different or didn't differ between the 3 subtypes that we identified, the accelerated, delayed, and atypical. So generally, all these 3 subtypes have an increase compared to the typically developing individuals, have increased the negative exposures. That's a general sort of pattern, no matter what you're going to look. So at the top, you have maternal alcohol and substance use or maternal use of prescribed medications. Then you see the CBCL, which is a very widely common instrument that measures behavioral deviation in young people. So you have higher levels of both internalizing and externalizing behavior. And then we come to the general cognitive ability, that is actually higher in subgroup 1, which is the subgroup with the accelerated brain maturation, and much lower in the subgroup with the atypical development. And this kind of resonates with findings from epidemiological studies where you have essentially 2 subgroups of patients with bipolar disorder in terms of their premorbid academic functioning, one which is high functioning, one which is average, and one which is actually low. And you can see that the risk really is highest at the 2 ends of the spectrum. And this is really captured here in terms of corresponding patterns of brain maturation. Everything else, as I said, was very similar across the groups, but the typical group usually had the worst or the biggest burden of adverse exposures. So coming to the end, so what I have showed you is that we have a range of resources that we are happy to use to collaborate with people on bipolar disorder and other clinical populations. And we show here an example where using a large cohort of adolescents with presenting with early mood and anxiety disorders, we have shown that aspects of brain development, either accelerated, atypical, or delayed, seem to be associated with the disease expression. And without significant differentiation in terms of exposures, but significant differences in terms of cognitive function. And moving to the future, we are going to see how these clusters evolve and whether some of the individuals that start with an early mood disorder seem to get better or have no symptoms, if their developmental pathways are normalizing the early abnormalities that we see in their brains. And that's it. Thank you very much.
Thanks, Sophia, for that great and efficient overview. There are a couple of questions in the chat, so I don't know if you see them, but I'll read, unless Benoit, you want to unmute, but Dr. Malsand is asking, there's a 2.5% prevalence of bipolar disorder, which is higher than diagnosis of depression. Wanting to make sure.
Yeah, absolutely. That's why I mentioned the issues about the case ads and that it's not absolutely perfect. And of course, the aim was to have individuals that are as representative as possible of the community population. Has there been some sort of sampling bias within the ABCD? Absolutely, yes. Is this reflected a little bit on the diagnostic breakdown of these individuals? Absolutely. But give or take, even if we think that the numbers are not necessarily completely representative of the prevalence that we expect, at least the diagnostic levels are, give or take, correct. So we can kind of make inferences based on that, being mindful of the fact that these individuals may not be completely characteristic of the individuals that you would collect in a community sample.
Another question from Brad McIntosh regarding subtyping. Why is it that there are no healthy controls in the quote participant number HYDRA findings?
Because the controls are used as the reference. So all the clusters that you see are clusters that differ from the controls. So the controls, as I said in the very beginning, there are about 3,000 typically developing controls that use those controls. But the output of the HYDRA is not a case control comparison, it's a cluster, the cluster or clusters that's significantly different from each other and from the controls.
Thank you. And then one more question here is
ADHD, yes, we excluded individuals with ADHD.
Okay. Any other last question? Okay, thank you so much, Sophia, for presenting to us.
So is it okay if I stay on for a little bit longer, but leave halfway through Steve's presentation?
Absolutely. You can do a silent exit or you can wave by however you like. Thank
you very much. And thank you for the invitation and the opportunity to share this information with you.
Yeah, this is great. So it's an honor, Dr. Stephen Strakowski, who is currently serving as the Joyce and Ivor Small Professor and Vice Chair of Research at Indiana University School of Medicine. He also served as Professor of Psychiatry and Associate Vice President of the Regional Mental Health at the Dell Medical School at the UT Austin. He was previously Vice Dean for Research at Dell and at the University of Cincinnati. He served as Senior Vice President also at the University of Cincinnati. Currently, he is Treasurer of the National Network of Depression Centers, Director of Strategy for the American Brain Coalition, and serves as Editor-in-Chief. Steve, we had a previous session like this with a couple of editors, so we may call you back in future years. So he's Editor-in-Chief for the Journal of Mood and Anxiety Disorders, which is the Society Journal for the American Depression and Anxiety Association. Dr. Strakowski is internationally recognized and trusted expert in the study and treatment of bipolar and other mood disorders, and his group has done world-leading research on treatment outcomes in neurobiology. He's also leveraged his observational skills in terms of clinical encounters to lead work to improve racial equity in psychiatry and delivery of mental health services accordingly. He's recognized as a best doctor in U.S. News and World Report, as a top 1% psychiatrist, and continues to see patients. Steve also is an avid musician. It's not in his bio, but he is. Over to you, Steve.
Thank you. No, if you can call being a bass player in a rock band a musician, then sure, I'll go with that. Let me share my screen here. And where's the silly, yes. All right, good. Can everybody see that and see my pointer? Yes?
Yes.
Yeah.
Okay. Good. So I'm going to talk about really similar to what Sophia did, talk about how our group's been thinking about bipolar disorder for the last couple of decades. Really myself, Melissa Dobello, now George Almeida, Beth Lippert at Austin, Cal Adler. It's a large group that have been collaborating. And so I'll present some older data, and then I've got some preliminary stuff of how we're working on the problem. And we're really interested in trying to understand the underlying neurobiology, ideally to lead to some sort of treatment improvements. I want to do my disclosures. I serve as the psychotropic DSMB chair for what used to be Synovian, but recently in a takeover became Sumitomo, and I think I'm spelling it right. This really just happened. I do a fair amount of work on Medscape, which some of you may have seen, and then I edit a book series for the Oxford University Press. Also have, I forgot to add that I have some funding from Janssen for clinical trials through IU. So when we think about it, we like to start with what's the condition look like, and all of my comments are relevant only to bipolar 1 disorder. We never mix the types, and so we've really focused on people who've been manic at some point in their history. And so most of this you already know. Mania is a big part of our focus. Mania typically emerges between 15 and 25. The STEP BD found an onset of illness of about 17. It's a very predictive syndrome. I continually argue that is the single most predictive syndrome in all of psychiatry, that when mania occurs, you can expect a lifelong history of recurrent affective disorders that include mania and depression. I'll talk about the latter maybe if we have time a little bit. It's very heritable. Again, it's the most heritable psychiatric condition, with the heritability rates running up as high as 85%. In the last few years, we've really stopped thinking about, and this is a little controversial, and I haven't written this up enough, but have really thought more about mania as a reward processing disorder, with the mood symptoms being secondary and are related to emotional signaling. Again, if we think about how the brain works, moods are not an end goal. Moods and emotions are the brain signaling us to do something. And so we think about mania more and more as a reward processing condition where there's a hypersensitivity to reward. Sherry Johnson's group in UCLA has done a very nice job of discussing and reviewing this, the behavioral activation system approach to mania, which we have increasingly adopted. That's really not what I was going to talk about mostly, but I just want to put that out there if we have time. Glad to discuss it. Unlike schizophrenia, there is not a well-defined prodrome, but there are a number of investigators who've attempted to come up with a staging as the illness emerges in adolescence. And we have a large at-risk study going now, but have also focused heavily on first episode cases. And in general, most of those cases have had some kind of psychiatric problems beforehand, which is not surprising given that this is a genetic illness. So you would expect there to be effects even before mania finally emerges. Unfortunately, they're fairly non-specific things like just a depressed mood, anxiety, ADHD kind of symptoms. I'm going to show some data in a second. The initial course of bipolar disorder is probably progressive in the sense that well periods diminish over time, the duration. All this together tells us that this is probably a neurodevelopmental condition that emerges with adolescent brain developmental changes most of the time. And it also tells us that it involves brain systems that are involved in reward processing and the associated emotional signaling. And so our work really has focused on that now for probably 20 years, maybe longer. These are just data. I've used this slide for almost that same length of time that I've always found just fascinating. But these are data that show the well period between mood episodes as the number of episodes accumulates. And so between the first episode and the second, we have our first well episode. And between the second episode and the third, we have our second well episode. And Kreplin, through his documentation 150 years ago or 125 years ago, found this pattern that with each episode, the period between the episodes tended to shorten and then finally kind of stabilized after 5. 100 years later, Peter Royburn, when he was a bipolar disorder researcher before switching to anxiety disorders, showed the exact same thing in a sample of NIMH subjects. And so despite all the changes in culture and society and treatments, it continued to progress, which is always, of course, sobering, since it suggests we're not making a lot of progress on affecting the underlying course of illness. Now, in adolescence is an interesting period. And this is really just a cartoon, but it shows that it's a very different developmental stage in which the kind of subcortical and non-prefrontal parts of the brain get ahead of prefrontal cortical development, and it's uniquely different that way than earlier childhood or later adulthood. And so at some level there's a mismatch in adolescence between prefrontal maturation and modulation of other systems, particularly reward processing systems, and particularly within the setting of peer interactions. As everyone who's been a teenager or owned a teenager knows, that there is a tendency for heightened emotional instability, particularly linked to peer interactions and risky decision making. And many studies have shown that teenagers will make a very different decision based on a peer being present than when they're by themselves or with their parents, as again all of you probably remember or know. And there's lots of evolutionary reasons to think about that. I suspect ultimately it's a way to drive them out of the natal group and become independent, but which is the job of a teenager. But that's again another talk. But what's interesting about that, though, is the emotionality and reward hypersensitivity that we see in teenagers resembles that we see in bipolar people, and in mania, of course, in a much muted form. And so again, it just adds support that something's gone awry during this critical period in the maturation of the integration of these systems. So this is just one example of some work we did where years ago we showed that this is a structural study, so its relevance to function always is questionable. But we showed that in bipolar people who are listed in blue, had a first manic episode and that we followed for a year, that the year after the manic episode, the normal development, what we normally see in teenagers in amygdala is a proliferation of growth, presumably as the threat detection system is maturing, that then is followed by some decrease in size, suggesting again changes in synaptic connections and dendritic density and probably myelination, and then meanwhile, and you see it in both healthy kids and kids with ADHD, so it's kind of preserved, even though ADHD, which is more of a cognitive disorder, in present, but in people with bipolar disorder, that does not happen. That maturation just doesn't happen. Again, I never want to suggest that these conditions can be localized to a brain structure, because I think that's just almost certainly untrue. And I think 30 years of imaging have shown us that. But it suggests that within the interactions of these systems, which are driving the maturation, right? Maturation is dependent on feedback and feed-forward relationships among multiple structures in a network. Amygdala growth fails in these kids, and that may be part of the underlying substrate that leads to a progressive illness. And so with all that in mind, and a lot of stuff, and we've reviewed this in a book. This is an old reference. There's a new version of it in 2022, which actually may be there. I just can't see it. That we pull the amygdala out of the middle because I think we've overemphasized that, frankly. But we tend to think about bipolar disorder then being a failure of the development of these two critical prefrontal networks, one of them ventrolateral and the other one ventromedial, that are largely independent, although have some intersection eventually as you move down the structure. And the architecture here is a typical prefrontal architecture for dorsolateral or any part of the prefrontal cortex, where it tends to map on specific parts of the ventral striatum, specific parts of the globus pallidus, ultimately on the thalamus, and then there's a feedback. And in healthy subjects, typically the feedback structure is a negative feedback loop. So you think about, again, does this make sense? Well, if you think about the ventral striatum driving parts, through dopamine expression, driving reward processes and reward seeking, having prefrontal modulation of that as in a negative feedback system makes sense. And when it becomes a feed forward system, then it may kind of cascade out of control, which is what we see in mania. And so we've focused as a team on this system now for many, many years, and I remain convinced that it's within these two networks, one or both of them, that developmental processes have gone awry, and it leads to substrate of risk for developing bipolar disorder. Good. So hopefully that makes sense. I just want to show a couple of older studies, but again, to support this reward processing problem. So this is looking at people with bipolar disorder and anticipating reward. And so these are even during the euthymic period. And so you can see on the left, there's a loss response within these brain regions and ventral striatum. But there's an excessive win hypersensitivity to reward, anticipating a win, and healthy controls. Both are fairly similar in how it's responded to. This has been replicated in a number of studies that have suggested that not only in mania is there a hypersensitivity to reward, which we're familiar with just from our clinical experiences, but even during euthymic period that persists to some level, although it seems to be somewhat muted and modulated better. And this same hypersensitivity to reward appears to be present prior to illness onset. So this is some work that Manpreet Singh's group did several years ago that showed that when you looked at people with no family risk or limited family risk for bipolar disorder, and then at high risk for bipolar disorder, there's a dramatically different reward response. And reward elicits a greater response in these networks than in healthy subjects. Whereas loss, is, one might argue, is even less responsive. It's a negative response, which is always hard to interpret in imaging. And so together, then that suggests to us that mania is a reward response disorder, and that the hypersensitivity or substrate for that is even present when people are euthymic. And our model depends on the notion that during euthymia, there's been enough recovery of prefrontal control that now mutes the hypersensitivity to reward, that then that recovery or that prefrontal control gets lost as people become manic. And so mania, many people have called mania kind of a prefrontal release syndrome for many, many years. And that is likely to be true. And so we're trying to understand what happens to cause that. And so part of that work then is really what we've focused on the last few years. We've historically tried to combine longitudinal research with imaging to look at dynamic brain activity or structure or function over time, to try to understand this dynamic illness, because it isn't one that just sits in a situation. It moves around. And the second piece of what we've been doing then is trying to use treatment as a probe. And so this particular study was one of first episode manic individuals who we imaged at baseline when they were manic with Young scores over 20 was our entry criterion. And then we scanned them a week later, and then we scanned them 8 weeks later, and looked at what the brain activation differences were across time among the group who did or did not achieve remission, which was defined as Young scores less than 10, and Hamilton depression scores, I think it may have been MADRS, I can't remember, less than 10. And so we So we're using, then again, the idea, the approach is that we use a starting point we can define, which is mania, and then we study it as time evolves to understand what's changing that produces this syndrome. We're doing it somewhat in reverse, right? The ideal study it would be to follow bipolar people, large numbers for long periods of time, and try to capture them and image them right before they become manic. Again, the problem we have is we don't have any predictors to say, hey, they're going to be manic in 2 weeks, and so you should scan them now. And so we've kind of done the reverse thing, thinking that the systems involved are likely the same, although they may not be, and they may actually, there may be two processes, one where you become manic and one where you recover, and we don't know that yet. So looking at this is just an example. So of that kind of work, we published a few years ago now. It's amazing how time has passed. We have healthy subjects, which are the dotted lines, just to get rid of that quickly, to look at, by participating in this study, what changes over time just by participating. And we're using an oddball task that has emotional distractors as our probe. And so it shows that healthy subjects, there's a little bit of change in brain response to that task just from doing it probably 3 times. And so we try to control for that by demonstrating how that works. Again, in a couple of areas, subcortical structures, anterior cingulate, it's largely flat. But in the prefrontal cortical areas and say the amygdala, then these are negative pictures involved in the emotional distractors. And so there's some changes, probably in accommodation, having the novelty having gone away and being able to expect the kind of image you're going to see. Then we compared, like I said, the people who remitted and those who don't. In a first episode sample, if we followed everyone long enough, that virtually every one of them will remit. And so at some level, this is probably a time to remission difference rather than an absolute ability to remit difference. And so keep that in mind. That will mute some of the findings, I think. We created factor models to try to decrease the number of contrasts. And so we had a subcortical, striatal, palatal, thalamic section, and then anterior cingulate, which stood alone, a prefrontal cortical, which stood alone, and the amygdala, which stood alone. And you can see that in the people who recover, who remit, like, for example, in the subcortical structures, there's not a whole lot of difference that the two look largely the same. We start to see some differences in prefrontal areas, and here the remitting group just starts with a higher activation level and is more likely to remit, although it's not linear, and the two start to come together. Again, my prediction is, if had we followed them long enough, we would see that the non-remitters followed a different path, but ultimately came to remission also. We've interpreted this as suggests that they may work an early, more reactive prefrontal cortex, one that is able to activate quickly, leads to a faster recovery, and that's what we think this suggests. And so we even see kind of a rapid increase in that then leads to a faster decrease in symptoms, and then it starts to stabilize as symptoms go away. And we also see that there's even though amygdala hyperactivation, which is very well now recognized in mania, is present in both groups, the pattern to how they finally lead to remission is quite different. And this is the remitted group sorry, my pointer keeps going all the way. The remitted group is here, and the unremitted group is there, suggesting that there may be something different about these two subgroups, and we would, maybe we would predict that perhaps they're on different stages in their progression, even though they've only each had one manic episode, or it could be that this is going to predict longer term, one group is going to have a worse course of illness than the other. We do not know that, but it's all part of, again, building a model. I'm going to skip this for time. And so recently then we've continued to really focus on this. The limitation to the study back here, and I unfortunately forgot to put in this slide, but if you look at the symptom resolution, there's a dramatic decrease in both groups during the first week that, again, clinicians are familiar with, that by getting manic people into the hospital, which all these were hospitalized, symptoms resolve quickly. And then there's a longer period of and that has nothing to do with medications. And then there's a longer medication-induced effect that takes several weeks to finally lead to remission. And so the actually interesting period of time that we didn't know didn't think through at the time, but we now are, is between week 1 and week 8, because this is all, the first week is really hospitalization effects. The week 1 to week 8 time is when we see medication effects and probably long-term sustainable remission. And so we don't have that information. So that's something we're trying to address now. To that end, then we've been looking at what happens again in mania as people remit with regard to connectivity within the network. So the last slides were sets of activations. So this is a connectivity diagram. Again, same networks. We always look at the same things. We've got medial prefrontal cortex through ventral striatum, pallidum, thalamus, and back. And then in this case, they're looking at left and right inferior frontal gyri as our ventral prefrontal areas. And what we found in the group, comparing the group that do and do not remit, is that there's a very robust, in fact, quite large effect change in the thalamic feedback to the medial prefrontal cortex. And there's medium effect size changes from both prefrontal areas into the ventral striatum. And so those are what are differentiating the people who do and do not remit. And again, what we believe and what we hypothesize is what's happening is that as people remit, their prefrontal cortical feedback changes within this network. And so the work we're working on expanding this now. We're also, as I mentioned, we have a large at-risk study going, and we're going to present the first level of results at ISBD and that for anybody who's going to be in Iceland. And so, so this is the model and the approach we are using currently, and how we think about the illness. And so, just to summarize, we believe mania is a reward processing failure that is accompanied by dysfunctional emotional signaling, right? So if you're hypersensitized to reward, the signaling to keep driving that is euphoria, right? Keep doing what you're doing. That's what your brain's saying. When you can't achieve it, the brain perceives that as a threat, and so it sends out anger or frustration signal, and so we see irritability as part of mania. That then resolves as it goes away. And we think it emerges in adolescence that there's because of some disruption in how these systems mature. And these systems do significant maturation from 15 to 25. It leads to a dysregulation of approach avoidance, threat and risk reward assessment. And there are data that suggest that during mania, this feedback system becomes a feed-forward system. We do not know why, but that's what we're trying to understand. Ultimately, we think if our goal is to prevent the first manic episode or mitigate against the progression of illness, understanding these systems and then developing interventions that modulate these systems. And the good news about prefrontal cortex is you can modulate it even with just cognitive behavioral therapy. So there's lots of ways to potentially intervene. We think that's what we're going to need to do to have impact on the illness over time. And so with that, I wanted to leave some time for questions, which I think I did, and stop there. So thank you.
Thanks so much, Steve, for ending on time, leaving time for some questions. David Miklowitz asks, can you explain how it would be that the amygdala decreases in size yet is more hyperactive during mania?
Hey, David, how are you? I didn't see you hiding in the group somewhere. So amygdala size changes. It's kind of interesting. And this is, again, the short answer is no, but I'm going to make stuff up for you anyway. You know me well enough that that's what I do. If you look at the old data, and you may remember this, like when the UCLA group years ago found that amygdala enlargement distinguished bipolar disorder from schizophrenia, and what we see that in kids the amygdala is small in people who are bipolar disorder, but then it is enlarged in adults, and we think that that's reflected in a dysfunctional developmental process. The hyperactivity then tends to have been mostly from adult studies, but I don't know that the size has any correlation with function. I think the function is really, again, I think it's a network failure, right? So that the hyperactivated amygdala is the brain firing off threat signals, the amygdala, the threat detection part of the brain sending off signals, and so it's hyperactivated to danger threat. And again, in mania, we posit that it's hyperactivated to futility of achieving rewards. Does that make sense? And leading to the euphoric irritability, lability of mania. So I made up a lot of stuff. So I don't know what happens. We don't know, but that's how we think about it. What do you think? I mean, you know more than I do about bipolar disorder.
No, I mean, I just find it very interesting. You know, is it really an amygdala feature? Is it a prefrontal cortical developmental process, or the interaction between the two of them?
I predict, if I could predict, it's the interaction. I think it's a failure of network development, not a failure of structural development. That's my prediction. Yeah.
Yeah, that's really interesting.
Steve, I'll ask a question. So if you look at the past 20 years, let's say, sample sizes have gone up, methods have improved, statistical and acquisition and everything, and it looks like progress is being made. If you forecast ahead as clinicians, what types of biomarkers might come to informing clinical trials, to diagnostic specification? What do you think is most likely to reach, truly translational application among all of them? Yeah.
I don't know if you saw, I wrote an editorial for the American Journal a while back in response to one of their papers addressing just that. And I'm old enough to remember when we started this, we predicted within 10 years we would use imaging to help diagnose and treat. And we now 30 years later have obviously not. And so my predictive abilities are to be challenged and questioned at every instance. But I do believe that the technology advances are so rapid now that it is reasonable to assume that at some point in the not too distant future, probably not before I retire, but maybe some of the younger folks will still be practicing, where AI-driven imaging acquisition may be useful to either help make diagnoses or help early on predict that this is a good medication choice, right? One of our goals with the 1 week scan was exactly that. We were hoping to say that we could show changes in the first week that would predict then that lithium or quetiapine were better choices for a given individual. That did not hold up. And I think the reason was we failed to remember that the first week is a hospital response, not a drug response. And so I think, and so both groups had the same hospital response and we couldn't distinguish it. But I do think there's a future for that. And between that and improving genetic analytics, one can imagine, I've said this for years and have been wrong continuously, that there will be a time that the integration of genetic markers and early neuroimaging changes will help us predict treatment response probably first and then diagnosis perhaps later. The other thing I didn't talk about is we're looking also at the profound impact of childhood trauma on all of these systems. And unfortunately, childhood trauma hits the exact same networks. And the rate of that in bipolar families is higher than the already high rate in non-bipolar families. And so the current work we're doing is integrating that impact and try to understand how it colors and flavors these networks and how we interpret differently. And I think that will matter. Charlie Nemiroff has kind of driven that into me over the years, so I believe him. Good.
Well, lots of comments in the chat here. Thank you so much, Steve, for this great presentation, and thanks everybody for joining in. We're past 1 o'clock now, so we'll let folks go. We'll be in touch about next year's schedule. So thank you again, Steve.
Good to see y'all.